Hello, everyone. Welcome to the University of Toronto Joint Centre for Bioethics 2024-2025 Bioethics Seminar Series and the 16th annual Sue MacRae Lecture on Ethics and Patient-Centered Care. My name is Andrea Bianchi, and I am very pleased to be the moderator for this year's Sue MacRae Lecture. Our speakers today are Nikki Gouzopoulos, Tekla Hendrickson, Dr. Kristie Serota, and Dr. Han Yan. And this seminar is entitled Navigating Grief in the Context of MAID, Ethical and Quality Considerations. The Joint Centre for Bioethics is pleased to collaborate with MAID House to explore this topic in today's JCB Bioethics seminar. And so before we begin, and I have the pleasure of introducing our speakers and actually having a word from Sue herself, I do invite us to open this gathering in a good way. And I'd like to acknowledge this land on which the University of Toronto operates and the land on which I currently live and work and play. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous peoples from across Turtle Island. And we are grateful, and I am grateful to have the opportunity to work and live on this land. And so today, and again, welcome everyone, the JCB Seminar Series and today's Sue MacRae Lecture provide a forum for exploring bioethical issues in contemporary health systems and settings. It seeks to engage a range of topics and speakers from a diversity of perspectives to foster curiosity and understanding through respectful dialogue, particularly around complex and nuanced topics about which there may be different points of view. The Sue MacRae Lecture on Ethics and Patient-Centered Care aims to explore the felt ethical experience of those who are sick or unwell, perhaps in their relationship to themselves, family members, caregivers, and/or systems of care. The goal is to understand how patient-centered or relationship-centered frameworks and best practices, inclusive of patient or family perspectives, can help illuminate and address common bioethical problems. Sue MacRae played an integral leadership role in all elements of the JCB's mission as its deputy director from 2001 to 2007. She is and has been a champion of patient-centered ethics, an innovator in building ethics capacity, and a leader in bioethics scholarship and education. Sue was instrumental in creating a strong community of practice at the JCB and played a key role nationally as the president of the Canadian Bioethics Society. And we are honored, absolutely honored, to have Sue MacRae with us today. She has graciously agreed to say a few words about this important lecture. And so, Sue, I'd like to welcome you back, and thank you for joining us. I'll pass it over to you.
Thank you so much, Andrea. I really appreciate that. And hello, everyone. Welcome to the Joint Centre for Bioethics and the 16th Annual Lecture on Ethics and Patient-Centered Care. I am so grateful for this lecture that continues to focus on this crucial intersectional work that is really near and dear to my heart. And it's that of understanding the lived experience of those impacted by our healthcare system. Over the past 16 years, this lecture has allowed a platform for patients, family members, clinicians, policymakers, bioethicists, and academics who value the inspired goal of patient-engaged healthcare quality. Together here, we've discussed topics on values-based practice, trauma-informed care, family-centered care, patient advocacy, the therapeutic relationship, the lived experience of those facing medical complexity, diagnostic uncertainty, and disability, the ethical considerations of aging, the care of the dying, palliative care, equity, to name a few. Our esteemed speakers for this series have allowed us to hear hidden voices, quiet voices, voices that don't often have a stage, and ordinary voices, unique voices, and our own voices as patients. And this is a voice truly that we all share together eventually, one way or the other. The question that all these speakers are reflecting on in their unique ways is, what would it be like to build an ethical, patient-centered, high-quality healthcare system based on real dialogue, which includes listening to the difficult, complex, and challenging realities of those who receive care and those who care for them. Today, our speakers will bring in yet another dimension to this conversation: how to navigate grief in the context of medical assistance in dying, or MAID, And for anyone joining that may not know this, MAID is legally available in Canada under certain conditions. My understanding is today's speakers, Tekla, Kristie, Han, Nikki, will discuss grief and ethical and quality considerations in this context. Important topics indeed. I understand we'll also hear a brief video from Karen Faith, a trusted and valued colleague of mine. So with these few words, thank you in advance to our speakers for what I know will be an important lecture, to Jennifer Gibson, the director of the Joint Center, to Terry Ewan and the Joint Center in general for hosting this lecture, and to all of you for attending today. It is my sincere hope you will find this helpful and that you will allow all of you to return to your life more grounded in the value of ethics and patient-centered care.
Thank you so much, Sue. Your words of wisdom and encouragement, and just having this lecture and having you here, it means a lot. So thank you so much for those words to perfectly start off today. And so enough of hearing from me, certainly. I will just briefly share the format of today's seminar, and then you'll have the pleasure of hearing our four wonderful speakers. So first, in a moment, there will be a brief video from Karen Faith, former vice chair for the board of directors at MAID House, and now bioethics advisor to governance and clinical practice committee at MAID House, as well as Joint Center for Bioethics graduates. Next, there will be a presentation by our speakers. And finally, there will be a moderated discussion period with you, with the audience. Please do note that today's lecture is being recorded, and you'll be able to access it along with other archived JCB seminars on the JCB's YouTube channel. During the discussion period, you're invited to pose a question through the YouTube chat function, or you can send your question via email to jcb.ea@utoronto.ca, and that will be put in the chat. Questions will be grouped by theme and summarized to ensure as many questions may be addressed during our time together. And now it is finally my pleasure to introduce today's speaker panel. Nikki Gouzopoulos is a compassionate and dedicated advocate for individuals navigating the end-of-life process. After serving as the primary caregiver for her father, she championed his right to MAID, which he chose in February 2019. In the wake of her father's passing, she was driven to support others on similar journeys. She became a certified death doula and began volunteering with MAID House on the Advisory Council and MAID Family Support Society, offering peer-to-peer support. We are also I'm pleased to introduce Tekla Hendrickson, who is the Executive Director of MAID House, which is a nonprofit organization devoted to providing those eligible to receive MAID with a supportive, inclusive, and comfortable space. Dr. Kristie Serota is a scientific associate at the Center for Addiction and Mental Health, working on the research and evaluation team for the 988 Suicide Crisis Helpline, virtual mental health and outreach. She has a PhD in public health with a specialization in bioethics from the University of Toronto. Her dissertation work on MAID bereavement earned her the JCB's Larry Liebrick Prize in Ethics and End-of-Life Care and the Paper of the Year Award from the Canadian Journal of Pain. Dr. Han Yan is a family doctor and MAID provider in Toronto. She is also a clinician scientist and assistant professor with the University of Toronto's Department of Family and Community Medicine. She is a Master of Science in Clinical Epidemiology, which informs her work at MAID House as a research consultant. Her clinical and research interests align with the common goal of optimizing end-of-life care for patients and their families. Nikki, Tekla, Kristie, and Han, on behalf of the JCB, welcome to today's seminar. Thank you for being here. And so we'll begin the seminar now with an introduction video from Karen Faith, and this will be followed right into the presentation.
Hello and welcome everyone for attending today's seminar, Navigating Grief in the Context of MAID. This is the 16th annual Sue MacRae Lecture. I'm Karen Faith and I welcome you as a member of the JCB community as well as past Vice Chair for the Board of Directors for MAID House, where I now serve as a bioethics advisor on the governance and clinical practice committees. I'd like to extend thanks to Dr. Jennifer Gibson, Sue MacRae, and Terry Young for their support in today's event. We are very fortunate to have such a distinguished panel, and the panelists will be introduced to you shortly. Those of us who have worked in the field of bioethics and healthcare know that the introduction of MAID brought with it unique challenges as well as innovations in end-of-life care. We are not here today to debate the moral legitimacy of assisted death. MAID is legally permitted in Canada under strict legal and clinical guidelines. As a relatively new practice, those involved with MAID continue to examine what constitutes quality patient care, while identifying key standards for ethics and professionalism in providing care. Through their research, Dr. Serota and her colleagues have enhanced our understanding of the lived experience of patients who seek MAID, as well as the experiences of their loved ones. Their inquiry has cast light on factors that contribute to the complicated grief and bereavement that can be encountered by loved ones. What will be shared today are stories that highlight barriers and gaps in care, as well as difficulties that can arise from problems in communication, different belief systems, and complex family dynamics, all of which can impact the grief experiences of loved ones. It is a particular privilege for today's seminar to be part of the Sue MacRae Lecture Series. For those of us who are part of the JCB community, Sue MacRae has been a respected mentor as well as role model for quality and compassionate patient care.
So thank you to Karen for those opening remarks, and also big thanks to the Joint Center for Bioethics and Susan MacRae, because as Susan said, that it's very important that we are having these conversations, that we're hearing from a variety of voices, and we reflect on what that means for our practice and how we move about our work. And sometimes people have very intense feelings, but that we need to take those feelings and be able to continue conversations and discussions around what is working and what is not working. So just wanting to framing the opening of where we're going with the information and what we're hearing is that we all agree that grief and bereavement are a natural response after experiencing loss. And while we're focusing on areas where that might have not been as positive or a mixed kind of experience, that's not necessarily everyone's response. That many people, yes, while they're grieving, is a natural process that they go through. Some of them, though, have complicated grief, and some of us experience that complication. And this is where we're exploring those dilemmas and the quality issues around that. So the other thing we just wanted to note is some of the characteristics that get interwoven with MAID aren't necessarily just focused on MAID, and there's other issues. So this is the opportunity for our conversations around quality improvement. So I'm very excited now to kind of hand it over to Nikki, who's going to share about her experience and carry on the conversation.
Thank you, Tekla. Good afternoon, everyone. I will be reading today because it's a bit of a challenge to sort of condense my story into the time that we have, so bear with me, please. As was mentioned a few moments ago, I found myself here because 7 years ago, my father, Zaki, chose MAID. It's the 6th anniversary of his death next week. It is sometimes hard to believe that it has been so long, in the same way I sometimes can't believe my girls are 9 and 12. I can say in this particular instance, the passing of time is really a gift. Grief is a trip, one nobody or anything prepared me for. I learned quickly that living in a death-denying society gives you very little tools, if any, to navigate grief. I felt a lot like I did after having my first child, people expecting my body and my sense of self to bounce right back, feeling as though I should be more okay much sooner than I was. Grief is an ongoing journey, one I naively believed would be easier for me because of all the anticipatory grief I had experienced from my dad. I had almost lost my father for the first time when I was 15 years old, and he had to have an emergency quadruple bypass. There was zero talk of the potential of his death and what that might mean. In the 10 years' time, I was my dad's primary caretaker in varying degrees, depending on how ill or hospital bound he was. I watched my dad almost die another handful of times. The difference this time was that I was married with my own young family and going through things like having thyroid cancer while simultaneously keeping a home and a husband, raising babies, and running my own business. This was incredibly ironic to me, given what a tumultuous relationship we had had my entire life. My dad was like another child to me. However, this one could be quite surly and rude, inappropriate with doctors and nurses, and generally not that much fun to be around. It was exhausting work, emotionally and physically draining, with days that felt impossible to believe that the system was not there to help or support us. Obstacles like finding appropriate long-term care, which he refused because he feared it would interfere with his ability to drink. His ability to drink, which left him having spent a night on his bedroom floor, not able to get up after a fall. You see, he was celebrating having a PICC line removed from his arm, which had been delivering a heavy-duty dose of antibiotics to rid his body of a sepsis infection. That celebration found me having to drop everything for the day while I got to my dad to clean him up, call 911 to help me get him off the floor. I hoped that this particular trip to the hospital would make him realize how serious our situation was getting and how my abilities and resources were becoming limited. It was a nightmare. The only upside to this particular fall was that he finally agreed to a lifeline necklace, so if he found himself stranded on the floor again, he could immediately call for help. I can't tell you the number of days I would find that necklace just sitting beside his bed. But those were the days he was getting closer to truly not wanting to struggle with his near blindness and lack of ability to bathe himself and do the daily things he once did so easily. It was heartbreaking to witness and very hard to be the punching bag to his understandable frustration. He was losing control, and that was an impossible pill to swallow. We circled back to MAID. After having had completed all the paperwork, but him not having been prepared to go the first time we initiated the process 6 months previous, we were now back to a final interview and him being certain that he just couldn't go on anymore. Life was simply too hard and not the kind of life he wanted to live. The final interview was scheduled, and it was immediately clear to me when the doctor met my father that he would approve him for MAID. Our doctor was lovely. He spoke the little Arabic he knew to my father, and that put him at ease and made him laugh. When my father was officially approved, he was the lightest and happiest version of himself I had witnessed in years. It's the kind of experience that I've heard many people experience with their MAID person, and sometimes makes you wonder, are they really ready to go? And he was. He was so ready that the 14-day waiting period was torture. He would call me first thing every morning asking me if today was the day. That call would be followed up by several more calls asking if we could move up the date. Waking up every morning thinking to myself, 14 days until dad is dead, 13 days until dad is dead, 12 more days. It was a peculiar situation to be in. I had a therapist, great friends, and felt as supported as I could be. But it would have been so much more helpful if I could have connected with others who had walked some version of this path. In fact, I remember the doctor asking me if I'd like a social worker to come and speak to me. My first and only question was, have they been through this themselves? The answer was no. Back to the countdown and feeling pretty lonely. The morning arrived at 11 a.m. on February 20th. My mother, my brother, and I were at my dad's to be with him for the last time. My dad was calm and ready to get started as soon as the doctor came through the door. There was no celebration of life. There was no hallmark moment of my father thanking me for all I had done and all I had been for him. But it didn't matter at that point. I had to stay strong. I had promised him that the procedure would not be painful. I would be wrong. I had left the room for just a moment, and in that moment, the doctor was clearing his IV lines. The vein in his left arm blew. I had known that the left vein was not as strong as the right. He cried in pain, and I felt I had failed him. I had assured him there would be no discomfort, and there my dad was, moments away from dying, and he was crying in pain. I crawled into his bed and lay beside him with my arms wrapped around him. I quickly asked the doctor if we could give him something to calm him while I wiped his tears away and whispered loving and encouraging words. He calmed, and I knew he was feeling peaceful and ready to go. I kept whispering to him until the distinct moment it felt weird. And I knew. I looked up and he was gone. The doctor listened to his no longer beating heart and declared him dead. I mentioned anticipatory grief. I really believed that when he went, it would be easy. I thought I would feel instant relief that the whole years-long ordeal was over and that my dad was free from his suffering. I would be set free from my responsibilities, and he will have died with his dignity intact. But really, I was just floating in numbness at first. Then I was met with a deep gratitude for the doctor who had helped us. What a hugely brave decision to make. This had also been met, with intense pride for my dad. My dad literally died my hero at a time when things were so new in Canada. I naively thought I would be met with a real sense of relief after months and months of advocating and holding space and dealing with all of the logistics while managing being mad and sad that my mom and brother had left it all to me. Needless to say, it was a challenging mix of emotions. And nothing prepared me later on for the anger and deep sadness of mourning the father my dad had not been to me. I now know what complex grief is. And I now know how wise the doctor was when he told me I should wait at least a year before I started any kind of volunteering within the MAID world. That, in the end, was my dad's parting gift to me. Our journey with MAID inspired me to become a certified death doula and volunteer on the advisory council with MAID House, as well as offering peer-to-peer support as a volunteer with MAID Family Support Society. I was able to contribute to this wonderful book, The Many Faces of MAID, which has been a great resource to many people I have supported. It was a beautiful, unexpected gift. It had been hard. There were moments in caretaking that were almost unbearable, but there were moments that I will always cherish. I still feel proud when I think of what I did for him. My memories have softened, and I mostly remember the better times. Now, when I feel the hole that he left behind, I don't stay in that dark void. The pain is quickly met with love. The love we shared did not go away when he died. And the grief I feel now, for the most part, is more of a reminder of how much I love my dad and how lucky I am to have had this relationship to miss. That's my story.
Thank you so much, Nikki. That was beautiful. Thank you for sharing.
Sure.
Okay, I'm going to share my screen now. All right, so my name is Kristie Serota, and I'm going to be talking about family members' complex MAID bereavement stories. So this was my PhD dissertation project that I completed while at the Dalla Lana School of Public Health in the Social and Behavioral Health Sciences Division, and doing a specialization at the wonderful Joint Center for Bioethics. If you'd like to contact me afterwards, my email is here. I will note that this research has absolutely no affiliation with CAMH. It was done completely at the University of Toronto. So from research across the country, since MAID has been legalized, we found that family members are very often involved with helping their loved ones access MAID in the planning, preparing for MAID, doing the paperwork, and as Nikki described, during the procedure itself. So for many family members, MAID is described as a very peaceful and gentle event. It can involve beautiful meaning-making ceremonies and rituals that can help the family process their grief before, during, and after the MAID occurs. There's also some research, though, that finds that MAiD can leave memories that are both comforting and distressing at the same time. And Frolic and colleagues, they describe this as a double-edged experience. So I became very interested in really diving into what this looked like. I found that internationally, this has been documented as well in jurisdictions where assisted dying is legal. So for example, in the state of Oregon, Srinivasan found that conflict can be, quote, a significant factor in the grieving process. And then in Switzerland, researchers found that passive family members, so family members who are less actively involved in preparing for and enacting this assisted dying, they can have more significant challenges than those who are more actively involved in the process. And then finally, in in Canada, Thangarasa and colleagues found that interpersonal strain and moral or religious opposition can cause, quote, a sense of distress that can extend beyond MAiD and into the bereavement period afterwards. And so in doing this literature review, what I identified was that nobody had specifically designed a project to speak to those people who had difficult, complex experiences, to really try and understand the scope of what was going on here. And so I designed this research project to really understand these family members' complex MAiD experiences through their stories. I wanted to know things like what kind of discordance is happening, why might it be occurring, and then how can the MAiD process and the MAiD bereavement experience be improved for family members, specifically family members who have these more complicated experiences. And so to do this, I used narrative interviewing, of course, because I was interested in soliciting and understanding people's stories. And I approached the research topic and my interactions with my participants from a care ethics practice perspective. So I wanted to position the participants really as the expert in their own stories and take a relational approach to understanding care. I identified the salient moral and ethical issues from the participants' perspectives themselves. So I wasn't looking to apply abstract ethical principles onto their stories, but rather, how are they identifying ethical issues themselves from what they went through? And then to do the analysis, I used this sort of interesting approach that bridged together narrative analysis, which takes a micro perspective at looking at the context of people's stories and meaning-making practices, with critical discourse analysis, which provides a more macro lens to look at how are these stories relating to discourses and narratives that are operating at a more structural level within institutions in our society more broadly. The entire project was based on a post-structural epistemology, and so I viewed the data, of course, as being co-constructed, non-linear, and performative. The study received REB approval, of course, from the University of Toronto, and I recruited 12 participants in about 13 months. So this was the research call for participants poster. Two of the main eligibility criteria was that it needed to be at least 4 months since the MAiD had occurred, because I was interested in understanding that bereavement period afterwards. And then also there had to be some kind of disagreement or difference in understanding or family conflict that had occurred. And so we identified that there were really 5 main factors that appear to be complicating family members' MAiD bereavement. The first, family discordance, so discordance between individual family members, but then also between family and the person who was accessing MAiD. Internal conflict, so this often included things like feeling as though your religious beliefs and your political beliefs are sort of in conflict with one another. Legislative and eligibility concerns, so feeling concerned that your loved one shouldn't have been eligible for MAiD. And this was the case for both track 1 and track 2. So whether or not death was reasonably foreseeable, people were experiencing these issues. Logistical challenges, such as scheduling the MAiD, and then managing disclosure and negative reactions. So disclosure to other healthcare providers, to family members, and even to people in their communities. I heard one story about a really negative reaction from a funeral director that had a big impact on an individual. So I'm going to share an excerpt from one of the narrative interviews from, we'll call her Gloria, and her husband accessed MAID. And I think that it really nicely shows a number of these different factors. So Gloria says, and I said, well, oh, sorry. And I said, well, should I tell the children? And he, the husband, said, no, I don't want anybody to know. I'm just going to do it. So we struggled with that. And I knew that if I had just phoned them one day and said, oh, your dad died, I kept saying, look, I'm going to be the one that's left with it, not you. So can we have a bit of a better plan? But it was this huge roller coaster ride. I would get ready for him dying, and then he would change his mind and say, no, I'm not ready. I don't want to die. And that went on for 2 years. So we can see in just this one small excerpt from one interview that Gloria is struggling with a lot of different things, right? We have disclosure and negative reactions, how to tell the children, whether to tell the children, who should tell the children, logistical challenges about scheduling and rescheduling the MAID, and then also perhaps some conflict between herself and her husband. And she describes it as a roller coaster ride. So I think this is a really nice excerpt that kind of shows a bunch of those different factors. Oh, my slides are not advancing. All right. So what we found was that really in line with previous research in Canada and internationally, some people's MAID bereavement experiences are still being marked by stigma. If an individual's need to be acknowledged was undermined in the context of MAID disagreement, then the resulting emotional pain could also be conceptualized as a disenfranchised grief. And so this was described by Kenneth Doka as, quote, a grief experienced by those who incur a loss that is not or cannot be openly acknowledged, publicly mourned, or socially supported. And so we found that there was also this compounding effect that happened for people who had very complex experiences. People who had generally positive experiences with maybe a few bumps in the road, they told us that they had less difficulty with disclosure and they felt like they received a good amount of support from their peers afterwards. Whereas people who had really complex experiences, sometimes describing it as a traumatic experience, they had more difficulty with disclosure, and then they had more difficulty seeking adequate supports afterwards. And so we came up with a number of recommendations for how this process might be improved for family members. So clinicians overall should be compassionate towards family members, especially those with complex experiences, and validate their feelings. Clinicians should also provide mental health resources to family members. And there's some really wonderful community supports and peer-to-peer supports that are available. There should be a greater integration of healthcare ethics consultation services, specifically in cases where there is discordance or family conflict, and there could be opportunities for mediation to occur, ideally before the death happens. There should also be more effective training and education for mental health professionals on sort of the specifics of what is unique about MAID bereavement. Some participants in the study told me that they went to their therapist after the death had occurred, and the first thing the therapist said to them was, I don't know what MAID is. Can you teach me about that? And that was really frustrating to the individual because they didn't want to be an educator. They were just seeking support. Fifth, that suicide or death support groups can be helpful for people experiencing disenfranchised grief and people who have really complex experiences with MAID. And then finally, that managing family expectations for what might happen on the day of the MAID procedure is really important, not to present sort of a romanticized notion of what's going to happen, because as we saw with Nikki's story, things can get kind of complicated and it can be quite difficult for family members who are present. So we have two publications that you can access. They're both published open access from this study. One was included with the abstract. The link was included with the abstract for this presentation on mapping MAID discordance. We also have an article on unacknowledged pain and disenfranchised grief. And then we have a forthcoming article that's in press with narrative inquiry and bioethics, where we look specifically at the dignity narratives that family members use when telling their stories about complex MAID bereavement. And that's it from me. Thank you so much.
Good afternoon, everyone. My name is Han, and it's my pleasure to share a little bit about my story and my experiences with MAID. So again, I'm currently a family doctor in downtown Toronto with the Department of Family and Community Medicine, but it took me quite a while to get there. And along the way, I had training in neurosurgery for approximately 5 years, both clinical and with a bit of research. And I would say if you look at two subspecialties within medicine, there are probably two that are very, very different from each other. Whereas before I dealt a lot with acute decision making, no minimal interactions with family, and as a resident, really spending a lot of my time in the emergency or the operating room. I now am able to actually have my own practice where I have several members of one family all under my care. I practice with both patients who are pregnant, but also patients who are more towards end of life, and a select few who are seeking MAID. So there's definitely a huge contrast in terms of the work I have done, but I think it's led me to where I am and where I hope to extend my practice into the future. So next slide. I will say that in my time as a neurosurgery resident, when I was doing a lot of work in the hospital, I never would have thought that I would be in a point in my life where I would be doing MAID or MAID assessments. But even in my time as a resident within neurosurgery, I felt that there was something quite off about how death was occurring in the hospital. Often in my situations, I would be seeing people who were in a terrible trauma or have suffered a stroke. A lot of patients were actually not able to make their own decisions about how they would like to make decisions about their end of life care. In the rare instance, they've actually had conversations with their family about whether they would want to be intubated or, pursue very advanced surgery. There would be the relief of the family member being able to express that thought to us. But more often than not, you're in a very tight situation where you make decisions and you offer, this could be life-saving, or at the end of the day, this could be something that detrimental. We can't predict all the outcomes. And there's not very much time to actually give families a real true consent process. And therefore, often we're found in the situation where we do a life-saving procedure, but not necessarily a quality of life preserving procedure. And I saw lots of patients who went from the operating room into the ICU where maybe they didn't fully wake up, or they were in a state where they could no longer make their own decisions about how they would consider their own end of life. And it's so hard because I think doctors want to really provide patient-centered care and provide everyone with the information that they would have to make accurate decisions. But there's so many times when decisions are made in such a small amount of time that no one is informed properly. And furthermore, I think there's such a huge disconnect from the physicians in the hospital who see so much acuity and understanding of what extended stay in the ICU could be like with patients and people who rarely see these instances. And for that one family member, it can be quite traumatic. And there were so many times when I would see an individual, perhaps in the ICU, intubated, and the family member would clearly say to us that, we've never had this conversation about death, and I would like to make decisions on behalf of my loved one, but at the end of the day, I'm going to be making, well, they would, you could see sometimes they were making decisions based on what they want, and no one wants their mother or their father to possibly pass away from pulling a tube that's based on their decision making. So there's often a lack of communication between family members. There's sometimes not great communication between the healthcare providers and the families making the decision. And honestly, sometimes there's just not enough knowledge to know exactly how to predict the outcomes for any patient. So whether a death happened because of a bad outcome, or whether patients were a long time in the ICU and there was eventually, after weeks or months, decisions about withdrawing a breathing tube, there were times when I saw families and patients not be together at the time of death, or perhaps times where we could never reach the family even. So overall, I think some of my reasoning from switching from neurosurgery into family medicine was because I wanted to provide more comprehensive care. And I think when you are a family doctor, you're able to establish longitudinal relations. So next slide. For the most part, I have my own practice. I have my own small roster of patients that I'm very thankful for. And I will say I'm fairly new into practice, but it's been great getting to know some patients and understanding their families. And I try to interject into some conversations, maybe sometimes not even when patients want to talk about it, but that it's important to have understanding of what your family members kind of want. And outside of my own practice work, I also do assessments and a couple of small provisions for MAID. And so in the rare instances where I've, been there for the actual death or been there for the family afterwards, since I'm so new into practice, I do see something dramatically different than what I see in the ICU or in the hospital. I see people actually gathering together, family members being able to support each other. And hopefully sometimes with MAID, you have the opportunity to actually plan. You have the opportunity to do a ceremony of life, or perhaps, invite all the appropriate people, have conversation weeks in advance. So in light of that, it's been something that's been very gratifying in terms of some of the clinical work that I do. Next slide, please. So to contrast Nikki's story, I also wanted to share one specific example that I've experienced with one specific family. For the purposes of this story, I'll call my patient Ellen. So Ellen was in her 70s. I was there for her assessment for MAID. And she was someone who did not have cancer, but she had very severe osteoarthritis and osteoporosis. For the most part, she was basically bedbound or chairbound. She needed the assistance of her husband and her walker to get up to use the bathroom every time. And the few times she got up in a day to actually make it to the bathroom, she was in extreme pain. She and her husband had been married for 50 or 60 years. They were, I think, high school sweethearts and had been together for the longest of time, both very supportive of each other. And as Ellen was starting to make the decision to do medical assistance in dying, her husband was very supportive of her. But even clearly during the assessment, when they were both there to answer our questions, I could see that he loved her. He didn't want to lose her, and he wanted to make sure that she was there. But at the same time, he was obviously a witness to her constant pain and suffering that she was going through every day. So ultimately, as an assessor, we look at whether the individual has the capacity, whether they have a severe illness, and ultimately, Ellen would meet all the criteria to be someone who could receive medical assistance in dying. So even during the assessment, we had discussed a little bit about how sure she was, who she had already had the conversation with, and it came up that at the time of assessment, only her husband knew, and they didn't really want to involve the children. They wanted the children to maybe have a few birthdays that they could celebrate, and then perhaps she would invite them for the actual provision. The day of the provision did come, and I was glad to see that she did have her 3 adult children in the room. And they luckily also had a religious person at MAID House where the provision occurred to kind of support and provide assistance for everybody. And at the time, I think that Ellen had the chance to say goodbye to each of her individual children. She had long conversation with her husband, so there was nothing additional there. But I could tell that everyone was very moved and not necessarily supporting of what was happening. We knew that Ellen wanted this, and she seemed pretty content and satisfied to move forward. But, as the final medication went in, as her head slowly started to slump, one of her adult children had to leave the room and they literally said the words, "This isn't right." And you could feel it's hard as a provider who is there and, really providing for the patient, for the medical assistance in dying, that you're there to treat the patient, but there's actually so many people around that individual whose grief and whose bereavement is not necessarily something that you're responsible for, but you've definitely have had a hand in. This is a rare family that I actually had a little bit of contact with afterwards, and that's because of my role as a research consultant for MAID House, where we as an organization also did some research on grief and bereavement following MAID. And so I was able to speak to the husband approximately, I think, 6 to 9 months afterwards, and interviewed him about his experiences at MAID House. And overall, I would say the husband was feeling that time has healed some wounds, that um, he was glad that Ellen was able to get what she wanted. He had always supported her wish to do what she had desired with medical assistance in dying. Nonetheless, you can sense that he obviously missed her and that he was lonely. When I asked about the children, since in this case I did understand what was going on, he said that they were moving on with life, that they still had family dinners, but it's hard to know whether right after that episode happened or the months following, how much conversation was had about how their mother died and whether that contributed to the grief in the family. So I think this is one example of many where we see that uh, grief in many forms will touch so many people. As a clinician, I think one huge gap in the current system is that we're assigned patients who seek our assistance for assessment and then the actual provision of MAID. But then if you're not following that family because you're their family doctor, or you just get disconnected because you're simply the MAID provider, there's no one really set in the system to look after families for grief and bereavement. And this is true both for MAID deaths, but also, if you're a surgeon following an oncology patient, or even if you're a family doctor where you don't have the entire family under your care. So grief and bereavement in many ways has unique elements with regards to MAID, and I've seen that personally. But I think it does apply to, deaths across many different causes. I'll be happy to take questions later on, but that is my little story regarding my experience with MAID and this particular family as well.
Thank you, everyone, for sharing their perspective, and Kristie's for her research, which is really giving us a framework to kind of hold these discussions. Just want to center a little bit, people, of what is MAID House. We're a nonprofit organization, and we provide a supportive and inclusive setting on the day of MAID for those who are eligible. And so we provide the physical space, but we also provide psychosocial support and emotional support for the person who's having MAID, but also for those who are supporting them. There is no charge for using our service, and most of our experience to date is in Toronto, though we are opening a second site in Victoria. It is important to know that we are not involved with the assessment or the provision of the MAID. We are not a healthcare provider. We are a community-based nonprofit organization. Kristie, if you don't mind. So one of the things that this gives us is that we are a unique moment in time. We are working with people at a very specific moment when they've been approved for MAID and they're thinking of their day of death, their day of provision. What we learn, MAID in and of itself, is focused on the patient, but we are interacting with a lot more people. So this has kind of given us an opportunity to learn about the intersection of MAID, grief, and bereavement. And as what we talked about before, grief is a natural occurrence around death. And when people come to MAID House, we say, no matter how much we do, and we're here to support you, you will have grief. But what we're talking about is some of the other components that can make that more complicated. So in addition to our practice in the community and the services we provide, we, as has Han talked about and was as a link when you registered, we have done a scoping review and done some individual research around the intersection between MAID House, grief, bereavement, and MAID, and looking at what are the things that are facilitators to support grief and how you're feeling, and what are things that can become a barrier as you're going through that process. What we also do know, and Kristie raised that in our research, that, we have to work around the normalization of MAiD and to reduce the secrecy and stigma, because we know that that has negative impact. And again, very grateful for Sue MacRae for having lectures like this where we can have conversations and discussions. And, as Nikki said, not making it all fluffy and rainbows, but talk about the things that go right and wrong and where are the opportunities for the support. So as I've mentioned, we're focused on the person who's eligible for MAiD, and MAiD as a system is really focused on the person who is requesting and who might or might not become eligible for MAiD. But what we found is many people are often surrounded by those who are supporting them. So when MAID House started, we really were focused on the person who was having MAiD, but as we were going through the planning for the day of, we got introduced, or that was the person around the primary support person. Also, after the provision and after the death happened, we were in the room with the people supporting them. So it really pushed us to think about how do we provide those supports, and how do we balance the need of the person who's having MAiD, but also those who are coming through the door supporting them. And that's really, and there is a lot of thought and discussion that needs to go around that, especially around the framework of MAiD, which is absolutely, as it should be, focused on the person who is having the MAiD. Nikki's story kind of addressed, and others have addressed, is that these are family dynamics that have been going on for years. So I had witnessed or been in room and I've seen things, and I'd bring it to our clinical practice committee and going, I wonder what we could do, or is there a way we could be supporting these? And Karen Faith, I remembered, and others had said to me, some of these dynamics, Tekla, have been going on for 30 years. Your short 2 hours or 4 hours or 10 hours of interaction is not going to solve that dynamic. So we alluded or talked about that as some of these things arise not necessarily because of having MAiD, but the family dynamics that are being played out around death and dying on the day of. So those are something that we're constantly looking around There's also the internal conflict. I have seen many people, or some people, who are not necessarily supportive or comfortable with MAiD, but they absolutely are supportive and comfortable with supporting their person having the right to choose. And so they are there for that reason. And then, as Kristie research shows, sometimes they need to process the feelings around that because they put those discomfort or what their thoughts are aside because they are focusing on the person who is having MAiD. In addition to the family, the healthcare system also has impacts around those dynamic and relationships. Next slide, please. So the other thing that happens are the logistical challenge. So there's the psychosocial, but there are the things that have to happen, like the transfer of the body, how much time between when the person is being approved and when they decide to have their data provision. Sometimes when that is, short time in between, it doesn't give people a lot of time to process. Also, when we're booking or dealing with MAiD, the family is dealing with a lot of logistics. And one of the most powerful statements in the many faces of MAiD that really struck me and also resonated with my experience is one of the people who supported someone with MAiD said, they were treating it like that I was going to the dentist, that I was helping my mom or my dad, book a day at the dentist, and that's not what it's about. So when we're planning and often talking to the primary support person about what the day of provision will look like, what they need to think about, what they need to organize, we always do say, we know this isn't just about the logistics. We do need to get those in place, but I imagine there's a lot going on for you. And then we're silent, and often we're met with tears, or more comes out about what they're experiencing, what they're feeling. But unless we gave that moment to pause, we could all focus on that logistics of what need to happen. And there is a lot of logistics that need to happen. A story that I want to share with you is around forced transfers and the impact on the person having MAiD, but also those who are supporting them. So there was a person who was having MAiD, and they were being transferred from an institution that would not allow MAiD on site. The their loved one and two other people, their small group had come to MAID House first because they had decided that they would do the transfer by themselves. We were waiting and waiting and waiting, and the transfer didn't come. I phoned the institution to say, what is happening? And they said no one had arranged the transfer. And this was in the context of, while I was storing with the people there, feeling that they were getting a lot of resistance to the MAID provision, and they believed that someone had purposely done this so this person couldn't access MAID. So we are busy with the logistics of trying to organize getting the person to MAID House so they can have their day of provision. They themselves are waiting for that to happen, and everyone supporting them had geared up for that day. To compound this factor, the person in the hospital did not have a cell phone, the other person did not, and they weren't able to communicate. Finally, a friend had gone in for a quick visit, and we got that call, and so we were able to move forward with that information. But can you imagine, you have the person who is supposed to be coming to MAID House who thinks this is their day of death and want to join their loved ones because they had booked time to have moments together in our space, and there are three support people going, where is the person? We want to be with them. What's happening? We're worried about them, and no way to address that. So luckily, an angel nurse in that facility got on top of it, and unfortunately, this person had given their street clothes because they thought it would be an easy transfer, put them in a taxi in their hospital gown, and I am sharing this experience with permission, and brought them to MAID House and got them upstairs. Because there was so little time, the people had a moment together with their loved one. And as you can imagine, when something distressing happens, it's about, how are you? What happened? Oh my goodness. And then it was time to move on the provision, where then they got to say that moment of goodbye. So they've been in a relationship and married for over 30 years. His husband, was trying to say the goodbye, but they didn't get that time that they had thought they would when they had booked to come earlier to MAID House for that time. So they had this distressing situation, and then really impacted in their moment of saying goodbye. So after the provision and we provided support, I talked to the primary support person who was super angry, and I asked for permission to talk to the hospital and to the bioethicists, which they did. And they didn't want to talk to them because, as far as they were concerned, this hospital was not happy they were gay. They were not happy that it was MAID, and they had done everything they could to talk them out of it. And when they couldn't talk them out of it, they had interrupted with the transfer to MAID House. So I talked to the bioethicist, who was fantastic, and led a process through to investigate what had happened. And they also tried to outreach to the primary support person, but that person had wanted nothing to do with them. So just told me what I could say in advance. And so through the investigation, what we found was that, yes, there was, before the provision, someone had said something that was not ethical. They should not have been trying to talk that person out of it. But that was a separate incident for what happened with the transfer, where there was just miscommunication about who was doing what. And, it was a bad system moment, but it wasn't purposeful. And they had done a deep investigation about that. So I knew that. And I tried to communicate that to the person who was the support person, but it didn't matter for them. The experience will be, and has always been, that they were deterred from and taken away from those moments from those loved ones, because that institution didn't support that. The MAID. That was further compounded because they couldn't stay in the hospital. It's, uncomfortable to be transferred. So that was their experience. And it definitely has impacted how they grieve and how they make memories and what they think about on that last day. Finally, around that, just around confidential address, we have a confidential address for a variety of reasons. But what we did find, which we've had to think about, and we're not able to change our practice, is someone said, there was a stress on about the confidentiality of address, and we understand why you need to have that, but ultimately that made us feel a bit ashamed that maybe we were doing something that was wrong or supporting something that was wrong. So that was something for us to reflect on, about how we message that and what we can do to reduce that feeling for people. So in terms of a community-based recommendations and things we have learned is, looking at the impact of location for the day of provision, how that's set up, where it is, do you have to move from where you are to us, what do you want to have around that, the opportunity to facilitate meaningful moments so things aren't rushed, that you manage transition, there's opportunity for ritual or to reflect, so you can reflect on, but not if you don't want it. Some people are very clear, they just want it like a medical appointment. They want to come in, they want to go, the people will go and they want as little time in between each step. The importance of planning this conversation so you don't have those moments where you say, oh, I wish I'd known that, I would have done that. Or as Nikki said, if she had had that moment where the MAID provider said, hey, can you tell me a little bit what's happening, or asked about the IV, that might have been prevented if those communication systems were flowing, and taking those moments for final words. The other thing that we do in terms of trying to provide supports is we do a follow-up call about 3 weeks later, and we're now offering a follow-up call 3 months if people want it. And what we do find is people really appreciate the 3-week call, and we're getting half and half about whether people feel they think they need more support or not. The final recommendations are make sure you're informed of resources, that they need to be inclusive or reflective of MAID. So there's no point sending someone to a MAID support group who is not comfortable or aware of what MAID is. And Kristie's research talked about that, when someone went to counseling and they had no idea what MAID was, that MAID is important, and looking for supports prior to the day of MAID. And Nikki's story really illustrated why that's really important, the day of MAID, but also after the day of MAID. And that we've all, I think, stressed that there are many people who are touched by this experience. So while MAID does focus on the person who is eligible for MAID, we as a system need to look at and be available to support those around them. Kristie didn't go through these because she knew I was going to highlight some of the community-based resources, but in the community for supports, and Kristie, if you don't mind flipping the slide, there's MAID House. Nikki's also talked about MAID Family Support Society, who provides support, peer-based support to those who are supporting someone having MAID, and they can talk to you prior to it happen, just when it's happening, after it's happening, and they have the book. Bridge C14 works with people having MAID and navigating those requests, as well as offers grief and bereavement. My Grief from Canadian Virtual Hospice is an excellent online resort. They also have MAID material for the pre that is also very good. And then Wellspring, which is cancer-based, has a support group where they, the intersection between cancer, MAID, and being a spouse, and that's also available. If you're interested in more first-person stories, we have MAID journeys on our website, The Many Faces of MAID. There's a graphic memoir from Sarah Lovett, who explores grief and her journey with MAID with her partner, and it's called Something Not Nothing. And then Jill Bodek has done Love into Being, where she supported her dad who had a stroke, and it was around his recovery and rehabilitation, and it then became a MAID story, which she wrote and did with her father. So those are some first-person stories if you're interested in more diverse voices. So that is our presentation, and I believe Andrea is going to come on and help facilitate the questions. And the rest of us are going to join and be here for those questions.
Lovely. Thank you so much for each of your stories. The presentation, sharing all of those resources. That was incredibly impactful. And I think you spoke to so many themes that are relevant to the named lecture that we have today for Sue MacRae. And I'll leave it to Sue to comment on that, certainly. But just to turn it over to the audience and highlight that, of course, as mentioned, we are at a time for questions and discussion. So if you have a question, please feel free to put it in the YouTube chat. I think some of you have already started started to do that. If you aren't logged into YouTube or you want to ask a question anonymously, you can send your question to the email address that's put there, jcb.ea@utoronto.ca, and we'll make sure to get to them. And so I will just turn it over to questions. The first one, actually, and you may have responded to part of this, but around in relation to some of the resources you actually just shared, are some of them peer-to-peer resources? And perhaps even Nikki, you can speak to kind of your role in taking this on after your father's passing. I'm not sure if that question's initially for Nikki, perhaps, or for Tekla in regard to the resources.
Tekla, you go first.
Oh, I was going to say, Nikki, you work with them. So you just tell the First Wife MAID Family Support, peer-based, an excellent organization that we try and highlight when people get in contact with us.
Yeah, so I've been volunteering with them for a few years now, and the peer-to-peer support bit is just, to me, that's the most valuable thing I think we can offer, and the thing that I certainly needed the most. And the feedback is generally so positive that people are just looking for somebody to speak to who get it, because there's so many issues that we spoke to, like whether it's, I feel like there's nobody else I can talk to. I'm afraid of being judged. I come from a religious background. There's so many things. So we're a really safe place for people to land. The book that I showed you guys before, that Tekla also mentioned in the slideshow, I think would have been an incredible resource to, sorry, you can't really see it, but anyways, it's in this slideshow there for you. Also a great resource of just, little snippets of different parts of the journey, and you can just get little sense of different people, different relationships, because it's truly is so unique to everybody, the experience. And I know I spoke to some of the not so nice moments of my experience, but it was beautiful in the end, and I am so grateful, and I wouldn't have had it any other way, and I know my father wouldn't have had it any other way either. So
and I think we see, our research showed, and also I see during the days of provision, is that family members each deal with that on their self. So sometimes you have the person having MAID who wants it secret, but you're actually fine with it and want to talk about it, but that limits how you're going to talk about it because you want to actually process, or that is part of the experience. So again, MAID family support, sometimes a peer-to-peer where you know that it's outside your community. Sometimes you're fine with it, but a sibling is not fine with it, and they say, I don't want you to talk about it. And then, of course, we have some people who say it was never an issue, where, it's in our obituary, where we're happy with it, but different dynamics within that whole family situation as well about comfort level. And sometimes it is the wish of the person, and not because they're shamed, but, they're private. It's health, it's their own business, and they wouldn't necessarily talk about their cancer journey or whatever other sickness they wouldn't share. Why would they share about that?
absolutely.
Thank you so much for offering that additional information. Your experience is there, and some valuable resources that people will inevitably benefit from, just based on some of the questions. And Nikki, I will share, there's a couple of comments just thanking you for sharing your story and how impactful that was. So just thank you on behalf of everyone who put those comments and beyond. There's a question just in regard to, Kristie, I think some of your research and the recommendations that were established, if they were established with the input of family members, if they were primarily established once you completed your analysis, if you could just speak to some of that.
Absolutely. So during each of the interviews, I asked, what resources did you access? Was it helpful? Was it not helpful? What do you wish maybe had happened instead? What did you learn from that experience? What would you recommend for other people to do if they were in a similar situation to you? And so I used all of those recommendations and experiences to compile that list of recommendations. Yeah. It would be
And
really
I think
wonderful. Oh, sorry. Yeah. It would be really wonderful to actually work iteratively with a group of people who have MAID bereavement experience to come up with a list of recommendations, but that is not what I had done for that project.
And it was interesting because the conversation, the Sue MacRae lectures are about discussion, as Kristie's recommendations generated discussion around the panel, especially the one around suicide bereavement groups. And we're like, well, MAID's not suicide. And I haven't heard that before. So we got Kristie to kind of lead us through where that got on and how that's a recommendation, because that wouldn't have been something I see or ever heard of that someone would need, and that conflation of those two things. But Kristie really, you know, could pull out the research and show us for these two or a couple of people was. So then we accept it's like, okay, that's not what I've experienced or what we know from our research, but for those people it was important. So this is why we have to be open to these conversations and discussions.
Absolutely. Thank you for that. And thanks for sharing again, Kristie, kind of what informed your recommendations. That's very helpful. A question came in, and it is in regard to social workers. And I think this stems from the story that you shared, Nikki, and your experience in being asked, do you want to speak with someone? And you saying, do they have any personal experience with this? And if not, then kind of not interested. And so there's a question just around whether you have any suggestions for social workers, that's the question, supporting patients, families who don't have personal experience with MAID, but I'll actually expand it just beyond even social workers for any healthcare provider who's working with a patient family. If they don't themselves have any personal experience with MAID, are there things that they should be considering to ensure they are providing adequate supports? And probably each of you can comment on this, but I'm not sure who to turn to first. If Nikki, you want to comment, or Dr. Yan as well, just based on your being a clinician working with people, any thoughts to share there?
I mean, my first thought is just for me personally, I felt what I needed was to speak to somebody who knew what it was going to look like. That is what I felt was going to give me sort of the most amount of strength in the day to be like, okay, I kind of have a sense of what's going to happen. So it's not to say that a social worker wouldn't have things of value to offer. I hope that that's not, that's not what I'm saying. But because I had a therapist and I felt well supported, and, I just thought that was going to be the most important thing for me. And now, having supported people peer to peer for years since it's happened, I will say the feedback is just the proof of the pudding that I think the peer-to-peer support is the most important thing. I think we need community. And I think that's having to being able to connect with people who know what you're talking about and who aren't going to judge you is just a huge piece. So that's my take on that.
Yeah, I totally appreciate what Nikki's saying. And I think something that I've been thinking about a little bit as well, because my research interests will probably be around end of life support. And I think sometimes about who you have supporting patients and families, and you think, oh, maybe the family doctor. But to be honest, like, you're training as a family doctor, you may not even see that many deaths. And I think because you're dealing more often with healthy patients, and like I was able to unfortunately witness a couple during my training, but more when I was training to be a surgeon. And, it's interesting about to Kristie's work when she talks about how we need to have more education around MAID in of itself. We need to have more education around grief and bereavement. It's not a topic I don't think that's addressed that much. And I think, honestly, I think not every physician is necessarily even equipped, so not to say even like social worker, to talk about this. And I also really resonate with Nikki's experience about how she felt after pregnancy, since I also deal with OB patients. Both birth and dying are huge, life-changing, family dynamic type of experiences. And it's so hard as a clinician to counsel people about what to expect during labor or what to expect during the day of dying. And I actually find a lot of parallels in what I can provide as a clinician who I've seen many patients go through it, but have I gone through labor myself? Have I had many close like family members undergo death and seen it myself? Since my family's abroad, no. But like, what do you do when you're a professional trying to provide that type of care that's so personal, that's so family based, but you don't have that personal experience? And I think I agree. The ideal situation is if you have that personal experience, but realistically, it's not going to be a thing that all clinicians, whether if doctors, social workers, anyone else, can have.
Thank you so much. The questions are rolling in. I am keeping up. So there's actually a comment just thanking you for bringing forward this the topic of disenfranchised grief. And recognizing it as a real issue. And there's a related question that also came in, wondering if we've ever compared or thought about disenfranchised grief in relation to MAiD with what occurred in the HIV/AIDS crisis. And, that person notes this might be another research topic. Maybe there's ethical quality considerations we can borrow or adapt there. But I just wonder if you can actually comment on the importance of recognizing disenfranchised grief, maybe reminding folks what it is, how it's relevant to MAiD, and just any reflections on your experiences there. And perhaps that's for Kristie to start off, I think.
Sure, I can start off with that one. Yeah, so disenfranchised grief, we sort of wrote a whole article about it as part of the research project because it wasn't something that we necessarily anticipated would be an important aspect of people's stories, but it really came out of the storytelling of people feeling like their experiences and the challenges that they had in regards to their loved ones MAiD were unacknowledged, that when they brought these issues forward, whether it be to the MAiD assessor or provider, or to the healthcare system, or to other members of their family even, people kind of said, oh, that's not a big deal. You shouldn't be worried about that. And really led them to feel invalidated. And so that invalidation made them feel like, oh, I can't talk about this. My grief is not valid. My grief is something that should be like hidden away and shameful. And so it kind of led to these cascading effects for people's complicated grief and bereavement afterwards. And so that was something that was unanticipated, but really came out of people's stories. I think there are probably a lot of parallels to other forms of stigmatized dying, including HIV/AIDS, as well as like the opioid overdose epidemic that is going on, and suicide and various other forms of dying, including homicide as well. Some people feel that those deaths are really difficult to talk about too, and receive adequate support back afterwards. So yeah, there's lots of different instances and kinds of dying that can kind of foster these disenfranchised grief experiences. So I appreciate the commenter bringing that forward.
Thank you very much for sharing, Kristie. Another comment came in just in relation to the value of death doulas. And I guess there's kind of two questions here that I would really value. Perhaps Nikki to start off, and then maybe Tekla to speak to just what a death doula actually is. So if you can speak to that, and perhaps Nikki, you'd be the perfect person to share what a death doula actually does. And then from the perspective of MAID House, kind of a practical question, whether a death doula is or would be available pre-MAID provision and post.
So a death doula can do many things, and depending on who you speak to, I've got other colleagues who are involved in the same work. Some of us focus on different things. So you might have somebody who will just support a family, not just the dying person, throughout the time leading up to the death and then after the death. Because if anybody is sort of like me, post-grief, it's your brain doesn't quite function, not post-grief, post-death, your brain doesn't quite function the way it normally does. You're overwhelmed with emotion. So to have somebody there to support you and to help guide you through, next steps, like if you need to execute an estate, that was one of the challenges that I had. I had no idea how to do that, and there was nobody to guide me through. So a death doula is somebody who can just help you sort of get through the system, find the supports, be the supports. The people that I support are specifically to MAID. But I know, others who are with people who will sit vigil if their person is on hospice or in palliative care. And that will allow people to, have a break. If you're the primary caretaker, like I was like, well, how will I ever go on holidays? Somebody has to be here for him. So a death doula could come in, and then you could have, some time and some space. So it's, and Han, you actually spoke to this, and I did as well. There's parallels, and it's almost like a birth doula, right? It's somebody else to come in. It's in many ways a social event, and the more support we have in a societal way, I think the more manageable these kinds of situations are. So, you know, I think it's got a new age sort of vibe to it, but really it's like the oldest thing in the book. It's about having community. It's about having somebody there to just sometimes hold your hand through the hard parts.
We've had death doulas come and support people at MAID House, but I think it's important to note that not all death doulas are MAID positive. So just because someone's working in death doesn't mean, so it goes back again to having to be careful about the supports and resources you access. We don't frame our service around death doula versus more about the community-based support and the pre-post and how we are looking at those logistics and framework. In terms of the HIV community, not around disinvention grief, but I think there's a lot of research opportunity that they've had huge lived experience, peer-based, community-based advocacy that's resulted in great changes to system, as well as really great, strong community-based support. So it's being pulled out of the medical system or, you know, enhanced. And I think there's opportunity with the MAID system, which is very much entrenched in a medical system, but yet we have these little community-based groups that I think could really empower the system. And I think HIV/AIDS has, if we actually replicated some of the learnings and hard learnings that they fought for and didn't have to fight for and incorporated that would be very interesting. And in terms of validating different emotions, Megan Devine has a cartography of grief, which we gave a postcard to everyone who comes on that has her cartography of grief, and then it has the grief and bereavement resources on the other side. But the purpose of that is it's a heart to say, you know, in the framework of love, you can have all these other different emotions, and her cartography of grief has positive and negative emotions. So we, as, you know, orienting people to their experiences, MAID House acknowledge that you will have positive, negative emotions, and we accept all emotions that are going to happen in this space. To that point of what Kristie's research and Nikki's found, that people don't always feel they can talk about everything. So we're trying to normalize that as they're going through the process through our doors.
And thank you so much for sharing, what a death doula is, the various ways that death doulas practice, and then in terms of MAID House, the opportunities for various types of supports kind of being offered. And that's very helpful to know about the cartography and the shape of a heart and that imagery. Thank you for sharing. I think we'll do probably time for one more question or so, but of course, if others do have questions or comments to add, please feel free. This is mostly for Dr. Yan, but anyone can of course comment just that as a MAID provider, you noted that people, that providers aren't given the opportunity to really look after families for grief, bereavement, very different than a family physician where you have an opportunity to develop a relationship, rapport. And so just from your perspective, should this change? Should there be an opportunity for MAID providers to establish relationships to a greater extent, to provide better support, or is kind of the separation and that specific role kind of keeping it quite distinct? Is that preferable?
Yeah, I would say I'm early in practice. I don't want to speak on behalf of all assessors and providers, but I do think it's basically when you're doing the assessment, often the family is there and you will have maybe form some relationships. If you're, especially the assessor who's also doing the provision, you'll probably have multiple encounters. And I do know that there's definitely some providers who they volunteer their time to connect with families afterwards. Whether, it's like MAID House a week after or something regimented, but they are doing that completely, out of volunteer work. So I think it speaks to how the system isn't remunerating doctors for that additional support that they're providing. And similarly, like I think even for a family doctor to talk about advanced care planning, it's not something that we have the time and to necessarily do within clinics, and where it's often long and repetitive conversations where we need to decide about when we even bring up different ways to think about end of life. So I think as a system, we realize the population is aging, that everyone should start thinking a little bit more about this. How do we fit it into the healthcare system so that more people can be doing it? And I will also speak to that, not everyone has access to family health teams, where sometimes the conversation is best had with a social worker or with an ethicist or someone, and providing those resources that are necessary. So in an ideal world, it would be great, because hopefully there are some relationships that are happening during that day. But also, as Tekla said, sometimes there are people who think of it as like going to the dentist in a day of like, this is something that has to be done. And I don't really want connections with the people who were there that day. And I want to wash my hands of the situation. So I think it's a variety of scenarios, and it could be very different depending on the family, for sure.
Perfect. Thank you so much. And so I'm mindful that it is 5:25 and there's a couple of announcements, and I want to formally thank our speakers. But before I do so, I would love to pass it over to Sue for some words.
Yeah, I just want to take a moment to thank each of you for this very thought-provoking and very landscaped review of not only ethical issues, but quality issues and also personal experience. It's such a, the inspiration of this lecture comes to this idea of lived experience. And I think all of you really demonstrated how powerful that is, that we hear people's stories. We hear, for example, Han, how you were talking about your professional journey and how you have come to this work and come to make these decisions, like how helpful that is. And Kristie, as you describe your work in qualitative research and really journeying alongside with that curiosity that research often brings, and of course Nikki with your touching and powerful story, personal story with your dad, and also the work you do as a doula, and then of course Tekla, your work in a system, right? In an organization that's trying to navigate these ethical, quality, personal issues. And, it's very powerful. So I just want to thank each of you. This has been I've been receiving texts in the background from people really saying how interested and how powerful this lecture is. So thank you very, very, very much on behalf of myself and obviously the Joint Center for Bioethics, who's hosting this. And yeah, appreciate all of your hard work.
Thank you so much for those words, Sue. It's such a delight to have you here, to be able to speak to your lecture and the impact that this presentation has certainly had on each of us who've attended. And so I will just make a couple of small announcements. And so before I thank our speakers, and so there is a conflict of interest. I will disclose that the next bioethics seminar will be on March 19th from 4 to 5:30, and it will feature a discussion panel of those who have contributed to a new edited book that's entitled Intellectual Disabilities and Autism, Ethics and Practice. It was co-edited by myself, so hence the conflict of interest, and Dr. Janet Vogt. We look forward to you joining us to explore this under-examined area of ethical practice and person-centered care. To sign up to receive the JCB's weekly seminar reminder emails, please do email jcb.info@utoronto.ca, and this will be put in the chat. So please do feel free to sign up there. CSB students enrolled in the CSB student seminar course, please remember to keep track of your attendance and coming to today's wonderful presentation. And Nikki, Tekla, Kristie, and Han, on behalf of all of us, thank you so much for, as Sue perfectly mentioned, this thought-provoking, incredibly important presentation for this named lecture. Thank you.